Move on with the talk. So today's talk, as mentioned, is on approach to neurodegenerative disorders. So in the next over an hour's time, the objective is to give you a broad overview on how to approach neurodegenerative disorders. And I won't be covering individual ones in detail. And we'll look at few case histories as well. So neurodegenerative disorders is a large heterogeneous group that results from specific genetic or biochemical defect, and can also be from chronic viral infections and varied unknown causes. But the main group we'll be covering here will be genetic, related to genetic and biochemical defects. It is characterized by regression and progressive deterioration of neurological function. There will be associated loss of speech, vision, hearing, or locomotion, and it's often associated with seizures, feeding difficulties, and cognitive impairment. So broadly, they can be grouped into gray matter diseases, white matter diseases, and system diseases, which involve other parts as well. So gray matter degeneration, the areas involved is a neuronal cells. So the gray matter is involved. Basal ganglia, the deep gray matter is involved. Cerebellar nuclei, ganglion cells of retina are involved. There's early and progressive cognitive impairment. There is seizures, and it's also, and depending on the deep gray matter involvement, you will have associated extrapyramidal signs. There could be cerebellar signs with ataxia, and there is pigmentary degeneration of retina. Some of the characters of white matter degeneration is where there's abnormal myelin, which breaks down rapidly. The earliest sign will be usually upper motor neuron signs and spasticity. Extrapyramidal signs are rare in this. Optic atrophy is most characteristic ocular finding. Sorry, so the differentiating features in a nutshell is the age of onset in white matter disorders usually is little later. In gray matter disorders, usually early on from infancy. The head size white matter disorders can have megalencephaly, but usually sorry, excuse me. So could have megalencephaly, and usually gray matter they have microcephaly. Seizures are late or rare in white matter disorders, and gray matter disorders they are early and severe. Cognitive functions are initially normal in white matter disorders. But in gray matter there could be progressive dementia. Although these features could overlap, the predominant signs are one, but later on the other could set in. Peripheral neuropathy, there will be early demyelination in white matter disorders. In gray matter disorders, this is usually late and axonal loss. Spasticity is early and severe in white matter disorders. In gray matter disorders, they appear much later and they are progressive. And reflexes can be absent if there's neuropathy or exaggerated in white matter disorders. Could be normal or exaggerated in gray matter disorders. And other things, cerebellar signs in white matter disorders can be early and prominent. Gray matter disorders, they're usually late. Fundus gives an important clue. Will show optic atrophy in white matter disorders. In gray matter, it is retinal degeneration. EEG in white matter disorders, nothing specific about EEG in between differentiation, but delta slowing in white matter disorders. And in gray matter, there's more chance of seizures and epileptiform discharges. EMG slowed nerve conduction velocity in white matter disorders, and gray matter they could be usually normal. And these other evoked potentials such as VP, BERA, etc. is prolonged or absent in white matter disorders, and usually normal in gray matter disorders. ERG is normal in white matter disorder, abnormal in gray matter disorders. Now, the other group where we have, in addition to gray matter and white matter, there could be additional systems involved, and the features will depend on the neural pathway involved. There could be additional stereotypical behavioral irritability, insomnia, development delay, such as an example of that will be Rett syndrome. Now, moving on to the approach. So as in any medical disorder, history plays a very vital role, followed by examination. And then from the history and examination, you can summarize to your diagnosis and differential diagnosis. And following on that, tailored investigations and management. Now, few things to be particularly asked for in history. So age of onset is very important. Seizures, cognitive impairment, school performance important, gait abnormality, spasticity, ataxia, dystonia, bradykinesia, hyperkinesia, behavioral, behavioral and personality change is important. Excuse me, can you please mute the mic? Okay, it's clear. Okay, faltering growth, visual and hearing concerns, acute deterioration versus chronic. So acute deterioration is usually in favor of a metabolic condition or a mitochondrial disorder. The child previously doing well deteriorates acutely with a febrile illness. Okay, other things in history. So the birth and perinatal history is very important. Antenatal period, congenital viral infections, decrease intrauterine movements, growth, liker, etc. All that things are important. Prematurity, low birth weight, perinatal asphyxia, neonatal jaundice, birth trauma, neonatal hypoglycemia, seizures, neonatal sepsis, meningitis, infections. All those things will matter in terms of our diagnosis and differential. So development history is very important. What is the development prior to the onset where they notice the problem? Was the development completely normal before? And you have to go step by step in all domains, all developmental milestones. Now, family history of consanguinity is important. Early onset deaths, affected siblings, and any other affected family members. Now, examination, general examination will give a lot of clues. We'll look into that in the following slides. Then thorough neurological examination and the rest of systemic examination, and then formulate the diagnosis based on history and examination. We'll come to that. Now, few clues in the examination. So head and face. So you could see dysmorphic feature in mucopolysaccharidosis, GM1 gangliosidosis, mucolipidosis, and Zellweger's. Microcephaly is a part of Krabbe's, NCL neuronal steroid lipofuscinosis, Rett syndrome. Macrocephaly is usually, on the other hand, is seen in Tay-Sachs, GM1 gangliosidosis, mucolipidosis, Alexander disease, Zellweger, etc. And hair can give you clues. Kinky or woolly hair is seen in Menkes disease, and fine hypopigmented hair in PKU. Now, the eyes can again be a window to the brain. Corneal opacity can be seen in Law's, mucopolysaccharidosis, and mucolipidosis. Cataract is a feature of galactosemia, Zellweger's, and cocaine syndrome. Cherry rod spot is seen in Niemann-Pick, Tay-Sachs, sialidosis, GM1 gangliosidosis, NCL, Krabbe, and Kahneman. And optic atrophy can give a clue to white matter degeneration, mitochondrial disorders, peroxisomal, and pecan. Now, pendular nystagmus is seen in Pelizaeus-Merzbacher syndrome and hypomyelination condition. Vertical gaze palsy is seen in Niemann-Pick. Ophthalmoplegia is seen in Kearns disease, and progressive visual loss is part of NCL, adrenoleukodystrophy, sialidosis, and MELAS. Deafness is seen in MPS, mitochondrial disorders. Hyperacusis is in Tay-Sachs, Krabbe. Hypertrophied gums can be seen in mannosidosis, mucolipidosis. Short stature in MPS and cocaine. And hernia can be seen in MPS, GM1 gangliosidosis. Hepatomegaly in Gaucher's, Niemann-Pick, MPS, Pompe's, GM1 gangliosidosis. Office tetanus posturing due to spasm of muscles is classical in Gaucher's disease. It can be also seen in Krabbe's. Skeletal dysostosis, MPS, and GM1 gangliosidosis. Stereotypical head movements are characteristic of Rett syndrome. Cardiomyopathy is seen in Pompe's, Friedreich's ataxia, fatty acid oxidation disorders, and valvular defects is seen in MPS and Zellweger's. Now, moving on to stepwise approach to neurodegenerative disorders. So the first step and the first question is age of onset is important. Has it started before 2 years or is it after 2 years? Because the causes are different and can give you clues on the etiology. So whether is it a static or progressive disorder? So that is the first question. And that for that, all that is what we covered in history, the important aspects of perinatal aspects. All these things are extremely important to answer that question. Now the next question is there a regression or is it purely just a developmental delay? Or is it a pseudo regression, which will come to that in the coming slide. So history is classical to differentiate this part. So what is pseudo regression? So it is usually regression happening secondary to other causes. So there could be associated intractable epilepsy, epileptic encephalopathy. There will be inadequate use of AEDs, such as used in very high dose inappropriately, or child is on multiple medications, antipsychotics, which could sedate the child and affect the development. Other intercurrent illness could affect. There could be a new part of a new behavioral problems. It could be due to psychosocial issues such as child development, child neglect issues, environmental deprivation, drug toxicity, progressive hydrocephalus, and unidentified vision or hearing problems. Sometimes simple vitamin deficiency, such as B12 deficiency, as we saw with one child recently, can also be the cause. Now, next step 3 will be the question is it CNS only or is there a peripheral nervous system involvement as well? So clinical examination along with the nerve conduction study will help you to clarify that question. Now, step 4, if CNS is involved, is it gray matter only or is it white matter only or is there both? And then the last step is, what about the other extraneural involvement? Is there hepatosplenomegaly? Is there dysmorphism? Is there skeletal involvement? Other systems involvement, like as we covered in the clinical examination part. So this is, so this is the same thing, just on a single page. So step 1, static or progressive. Step 2, regression, delay or pseudo regression. Step 3, CNS only or CNS and PNS. And if it is CNS, is it gray matter, white matter, both? And then step 5, dysmorphic features, other system involvement. And then from the history and clinical examination, you formulate your differential diagnosis, and differential diagnosis will come to that towards the end. Now, so neurodegenerative condition to see in a flow chart. So there's a cognitive impairment, seizure, retinal degeneration. So they are in favor of a gray matter degeneration. And the next question is there associated hepatosplenomegaly or no hepatosplenomegaly? Now, on the other hand, if there is spasticity, upper motor neuron signs, ataxia, optic atrophy will point to white matter degeneration. And the question is it only CNS or CNS and peripheral nervous system? Now, white matter degeneration again. So the question is CNS, if there's only white matter degeneration and so only CNS is affected, then your differentials are Canavan disease, Alexander disease, adrenoleukodystrophy, Pelizaeus-Merzbacher disease. And if there is macrocephaly, that will go in favor of Canavan, or if there is, and Canavan will also have visual loss, and it will also macrocephaly seen in Alexander disease as well. Now, if there is no macrocephaly, then your differential comes to Pelizaeus-Merzbacher, but in that, as I mentioned earlier, you may see abnormal eye movements, and adrenoleukodystrophy, where you would see additional adrenal involvement, which will give you the clue. Now, if this peripheral nervous system involvement as well, you come to these mainly these 3 possibilities: metachromatic leukodystrophy, Krabbe's, and neuroaxonal dystrophy. Now, the second part, gray matter degeneration, going to the flow chart with hepatosplenomegaly and with dysmorphism. So there is hepatosplenomegaly, there is dysmorphism as well. Or there is no dysmorphism, just hepatosplenomegaly. So if there is dysmorphism, and most of you would already know that mucopolysaccharidosis stands on the top with GM1 gangliosidosis, multiple sulfatase deficiency, mannosidosis, fucosidosis, and Zellweger. Without dysmorphism, you have this Niemann pick. On that, you see additional cherry red spot will narrow down there. Sandoff disease. Sandoff, you have exaggerated, spelling mistakes, exaggerated statal response. Gaucher's disease, again, where there's hepatosplenomegaly but without dysmorphism. So, but there you'll see the severe office tonus swallowing issues are prominent there. Now, without hepatosplenomegaly, there's a gray matter involvement. There is no hepatosplenomegaly. That will come to that. So, gray matter degeneration, and here there is a dysmorphism and seizures. So, if there's seizure as well, then what are the possibilities? So, with seizure, then we have these conditions: Zellweger, Lauf, sialidosis, GM, gangliosidosis. And without seizures, what are the possibilities? So, mucopolysaccharidosis, mucolipidosis, mannosidosis, multiple sulfatase, and fucosidosis. Now, gray matter degeneration without hepatosplenomegaly. So there is, with cherry red spot. Cherry red spot is an important clue which help you to narrow down the diagnosis. So Tay-Sachs and the sialidosis. Tay-Sachs has megalencephaly. Without cherry red, NCL with visual loss, Menkes disease, abnormal hair, Alpers disease. Now moving on to the next part, the investigation part. So you can draw clues from various investigations, and let's look at the peripheral smear. This is an important part of our investigation, which gives some valuable and useful clues. So vacuolated lymphocytes, as seen here in this picture, is a clue to about GM gangliosidosis and juvenile NCS. These are large. There's no pointer here, but there's a large vacuolated lymphocyte. And on the next one, you see in Pompis, there are like discrete, only small vacuoles. That is in Pompis. As Spears positive inclusions are seen in Pompis. Now, sea blue histiocytes, as you can see in the picture on the side, is a characteristic of Niemann-Pick disease. Gaucher's will give you crumpled tissue paper appearance. There is discrete, the nuclear on the cytoplasm, there is a discrete tissue paper type appearance. And neutrophilic granules, as seen here, can be seen in MPS. Now, MRI brain gives a very important clue towards narrowing down the diagnosis. So after the clinical examination, and I think one of the most important investigation based on particularly the CNS involvement would be MRI brain. So in fact, it has become an extension of clinical diagnosis particularly when it comes to the white matter degeneration, hypomyelination, etc. So pattern recognition helps you to narrow down diagnosis. So we'll look at if there's subcortical U fiber involvement, which we look at some of the MRI which is coming on. It is seen in Kahneman disease, Cairns-Sayre disease, and Pelizaeus-Merzbacher disease. If there's selective frontal white matter disease, white matter involvement, frontal, that is suggestive of Alexander disease. This is a OSCE question as well. So if there is selective parieto-occipital white matter, then it is Krabbe's disease. And you'll also see in metachromatic leukodystrophy, that sort of distribution. Corticospinal tract involvement is involved in ALD, metachromatic leukodystrophy, Kahneman's and Leigh disease. Tigrode pattern in white matter we'll see in some of the pictures seen in metachromatic leukodystrophy in Krabbe. And there's multiple infarcts which are not corresponding to a vascular territory as we would expect in typical arterial ischemic stroke. It is a feature of MELAS mitochondrial disorder. And contrast, in a lot of these leukodystrophies, you will see the radiologist just giving a contrast, because contrast enhancement will give a clue towards ALD, Krabbe's, and Alexander disease. Now, looking at this pattern recognition. So you have on the first picture, you will have picture A is predominantly the frontal involvement, and as we mentioned earlier, it is Alexander disease. Now the next one you have predominantly parietal occipital, picture B. So that is X-linked ALD, Krabbe's. Next, so the next one is subcortical white matter involvement. Sorry, 1 second. This person is hello. Hello. Urgent meeting. So parietal. Third is subcortical involvement. Which one? Felicis musbacher, you can see that. Yeah, this is from a cane sire again. Here you can see this is more of a subcortical. The cursor is not moving as much here. It's an old laptop. So so here the subcortical white matter. Okay, so it's coming on here. So more you can see the subcortical white matter is involved rather than the periventricular. So that will again give you some clues towards that. Whereas in this D, there is more periventricular white matter involvement, less of this subcortical, the U fiber, which is between the gyri. So that they are less involvement. So what is number periventricular? So metachromatic leukodystrophy. This usually periventricular white matter, subcortical white matter is paired. And here this is E is mainly there's a cortical atrophy is there, but there's only mild periventricular involvement, not much there. So that is a picture of a juvenile NCL. And there could be diffuse cerebral involvement in subcortical periventricular that is seen in hypomyelination disorders, ataxia with hypomyelination disorder. And cerebellar, the next number G, you will see more of a cerebellar involvement, which is a feature of cerebellar white matter, cerebrotendinous xanthomatosis, and involvement of middle cerebellar peduncle, as you would see here on both sides. There's usually an adult onset condition with LMN B1 genetic leukoencephalopathy. So based on where it is involved more, it can give you valuable clues on what test to order next. Now this, I'm not going through this flow chart. This is for the postgraduates. It's very important, very well given in Nelson's textbook about the biochemical defects and the what will give you the diagnosis, what leads to the various neurodegenerative conditions. So they are all in this slides. So now the diagnostic test for each one of them. So metachromatic leukodystrophy sample like the blood of fibroblasts. You have beta galactosidase is the diagnostic test. And then Krabbe's aryl sulfatase. Aryl sulfatase metachromatic. Adrenoleukodystrophy, very long chain fatty acid. MPS, urine mucopolysaccharides. Mucolipidosis in oligosaccharides. Menkes, Kinkes hair disease seen in serum copper, ceruloplasmin. Tay-Sachs disease, hexosaminidase A and B. Gaucher alpha glucosidase. Niemann-Pick sphingomyelinase, everything. And SSP, you see CSF. Yeah, there's I think that I noted that. So metachromatic leukodystrophy as there is a typing mistake. So aryl sulfatase A. So metachromatic leukodystrophy. So this we covered. This is a characteristic MRI picture, and here this is Krabbe's. So Krabbe's, you have periventricular white matter involvement, and there is also extensive cortical atrophy. So see this cortical gyri almost standing out. Unlike what we see usually more globular, so they were standing out, suggestive of cortical atrophy. They also have the internal capsules. There's some vacuolated things in the posterior limb of internal capsule, and again cerebellar involvement as well. That's what you see in Krabbe's. And again, this is a picture of hypomyelination syndrome, Pelizaeus-Merzbacher. So you see, this is a 3-year-old child. You'll see diffuse. Here, actually, this is T2 weighted MRI. So T2 weighted CSF is white, and white matter should be dark. But here you can see the white matter is still very bright after 2 years. Usually by this time, the child should have been myelinated. It should appear hypo-intense or dark. So that's Pelizaeus-Merzbacher. And this is a child with Canavan, large head, again, white matter involvement, and you will see this characteristics Na peak in MR spectrum. And again, this is a child presented here with acute regression following a febrile illness, and the MRI shows this globus pallidus and putamen hyperintensity, basic ganglia hyperintensity, which is usually suggestive of a mitochondrial. There could be other differential as well. And on further testing, clinical exam, the mitochondrial short chain acyl-CoA hydrolase 1 deficiency was found, which is one of the enzymes in that pathway. So now, what are the other investigation aids? So nerve condition study will help you to detect peripheral neuropathy. It will also help you to differentiate between axonal versus demyelinating neuropathy. So demyelinating neuropathy, which is the typical white matter involvement, is seen in Krabbe's disease, metachromatic leukodystrophy, X-linked ALD, Leigh disease, and Niemann-Pick disease. And VEP's visual evoked potential is also helpful. If it is prolonged P100 latency, it is suggestive of demyelinating disorder. If there is it's a problem with the amplitude only, then it is part of axonal disorders. Now, BERA or BAP. So if there is increased interpeak latency of waves 1 to 5, then that is characteristic of demyelinating disorders. But if you only see reduced wave 5 amplitude, it's suggestive of axonal disorders. Due to lack of time, we don't have time to go into the waveforms. But if the amplitude is low, then that is characteristic of axonal disorders. If it is delayed conduction velocity, then that is suggestive of demyelinating disorders. EEG is in terms of differentiating between the different conditions is not that helpful. But in one of the characteristic finding you will see in NCL is that high voltage occipital spikes with a photic stimulation. And in SSP, it will give characteristic periodic high voltage slow waves. Now coming to the management. So the child forms the center. Pediatrician plays a main role in coordinating the different staff. So all the other, it's a teamwork, and the therapy staff, physio, therapy, speech therapy, they all play a major role. In addition, we may need help of other specialists such as orthopedician, physical medicine, metabolic consultant, genetics, gastro, etc. So, and we have to look at the holistic management of these patients in terms of improving quality of life, even if there is no definitive cure, to improve the quality of life so that they can have a comfortable and pain-free life. So motor symptoms to address spasticity, dystonia, contractures, feeding issues are a major problems here. Swallowing assessment, safety of feeds has to be assessed because there is risk of aspiration and aspiration pneumonia. And you can consider other options such as nasogastric feeds or a gastrostomy feeds. If you have to depend on nasogastric feeds for a longer time, it's better to place a gastrostomy or jejunostomy and feed it that way. They can also use it to give medications to that. And dietitians help. It's also be helpful to optimize the calorie and protein intake. Epilepsy is often seen. It is important to consider appropriate anti-epileptic drug and appropriate dose. We, as far as possible, try to give monotherapy versus polytherapy because, again, you have to make sure the drugs are not being overdosed, causing too many side effects, which will further affect their development. Now, respiratory infections, aspiration pneumonia is another part of this syndrome, these sort of disorders that has to be taken care of. Other issues to be considered such as constipation, skin care, incontinence, menstrual hygiene, females, and all the other issues which come. So you have to look at the child in holistic care. Now there are some conditions you may have a definitive therapy. So bone marrow transplantation is an option in conditions such as X-linked adrenoleukodystrophy, metachromatic leukodystrophy, Hunter's, Hurler's, and Marotex-Lamy. Krabbe's disease, it has been tried, although the results are in early, they're not that dramatic, but variable results, and there are only a handful of centers which are doing that in India. Liver transplantation is used in Wilson's, can maybe need in glycogen storage disorders. Enzyme replacement therapy has come in a big way, and we have that in Gaucher's, Fabry's, Pompe's, Hunter, Hurler, and Marotex-Lamy. We are glad to hear that even IMCH was recently approved for the therapy. So we have we can get on insurance. So, and there are some voluntary organizations and with governmental help trying to provide, and parent support group helping to procure this enzyme replacement therapy, which is a very costly affair. Substrate reduction therapy is used in Gaucher's with miglustat. Now, some of the common treatable conditions are biotinase deficiency, Wilson's, Niemann-Pick, neurotransmitter disorders such as SAGAWA, tyrosine hydroxylase deficiency, cerebrate folate disorders, glucose transporter, biotin responsive basal ganglia disease, pyruvate dehydrogenase deficiency, creatine disorders. Now we look at a couple of cases. So in terms of how we approach them. So as an 18-month-old girl who presents with abnormal gait and limping, which mother noticed particularly after a trivial fall. Over the next few weeks, she has presented to the pediatrician with recurrent vomiting as well shortly after eating. There's upper respiratory tract. She gets recurrent upper respiratory tract infection with stridor. Birth history was unremarkable. Early developmental milestones were normal. Non-consanguineous relationship. No family history of note. On examination, normal vitals are normal. Weight is 50 centile. Head circumference is on the 95th centile. CNS-wise, higher functions, alert, normal comprehension for age, but there is some apparent dysarthria. Cranial nerves normal, extraocular movements normal, fundus is normal, gag present but decreased. There's motor, there's ataxia, there is hypertonia of limbs, with axial hypertonia. Reflexes are brisk with extensor planar sensitive spasticity. There's dysmetria is there. There's no hepatosplenomegaly, so there's no other systemic involvement. So now coming to, this sort of format will help in coming to a conclusion. So an acronym for that will be CAPE. So what is a clinical? So first, this is a clinical database or clinical summary after the history and examination. So in summary, we have a 18-month-old child with neuroregression noted after minor falls, recurrent emesis, stridor. And then you summarize your examination findings. So we have a child with large head. We have a child with a bulbar dysfunction. We have a child with a truncal hypotonia, with a limb spasticity, with the brisk reflexes and extensor plantar. So your next, so that is a clinical summary of the case. So then, that is what C stands for clinical summary. Then A is anatomical localization. So where would you localize this condition? Anyone want to volunteer? Is it white matter, gray matter? White matter. What else is involved? Cerebellar. What else? Yeah, so you'd see there is some stridor, there's some aspiration. So the bulbar dysfunction is also there. So it's a brainstem involvement. So your truncal hypotonia with spasticity suggests a deep white matter involvement. Now your decreased GRAG, stridor, and recurrent vomiting will suggest a bulbar dysfunction with brainstem involvement. Now gait ataxia and dysmetria would suggest a cerebellar involvement. So essentially the central white matter and brainstem involvement. So this okay, so pathology localizes. So next P stands for pathology. So in short, this is a gradual onset, progressive pathology causing white matter degeneration with brainstem and cerebellar involvement. So likely a sort of leukodystrophy. And etiology is genetic. So here, I mean, we're not going to we covered the findings. So the child had a large head. So this was more suggestive of Alexander disease. So that was one of the clues here. So due to lack of time, we may not go into details about each, but here this was the important part. So once you summarize your case into this CAPE acronym, clinical summary or clinical database, anatomical localization, pathology, what is the pathology going on, and then what is your possible etiology. So now we come to these four possibilities, and I think that will be the most important part of your clinical examination, the exam, and even for the clinical exam for the DNB or postgrad exam. And then there you can then say these are the investigation you would consider to narrow down further. Now we look at another case. So 7-year-old child. So history of being apparently a bit stiff on walking. That is what parents say. From 4 years of age. It's slowly getting worse. It's clumsy and is falling easily. There is no seizures. There is no cognitive impairment as such, but some behavioral or mood concerns. Although later on the time there was some cognitive impairment slowly coming in. Now birth, perinatal, no concerns. First child of a consanguineous relationship, no family history of note. On examination, higher mental functions are normal, no cranial no palsy. There's abnormal gait, spasticity is there, more of lower limbs, and no cerebellar signs. And this is that child. In fact, this is the photo of the brother. The brother was unfortunately affected as well. Get the index styles. This video. Sorry, I just tried to play that video. Okay, we'll show the video as separately. So that video was actually showing the spasticity, its child spastic gait. This child. Okay, now coming to let's come to the diagnosis. So what is a clinical summary? So it's a previously well child with progressive difficulty in walking. Examination showing spasticity. So what is the anatomic localization? White matter. So CNS white matter degeneration. What about pathology? So white matter involves pathology again, leukodystrophy, dysmyelination. This can come because mainly what you see the signs of a white matter involvement. And as you would say, even though earlier on it might be purely white matter, later on other things can set in as well. And etiology is genetics. So this child, this is the MRI which showed earlier. MRI showed leukodystrophy, parieto-occipital predominant, was suggestive of metachromatic leukodystrophy. Arousal saturated was low. Genetic confirmation was done on the index child. Parents both were carriers. Sibling was unfortunately affected as well. Although we tried to pick him early, he went on to have the one in the video went to have a bone marrow transplant, but has not done remarkably that well because the MRI had already started showing some changes by the time when we first saw this child. So usually, if it is pre-MRI, then the success of the brain marrow transplant is better. Hello. I could have. So now seeing another case. So 8-year-old child presenting with seizures, relatively normal development till 12 months. Then there is developmental arrest and gradual regression. There's loss of acquired skills and cognitive impairment, social withdrawal and autistic features, abnormal hand movements, ataxic gait, and later decline in motor function. Birth and perinatal history is unremarkable. I think most of you would have already got the diagnosis. So on examination, microcephaly, poor eye contact, no words and not following commands, no nystagmus, follow subjects, no facial asymmetry, is non-ambulant, there's increased tone, more in lower limbs, there's ataxic gait, the child is non-ambulant, there's abnormal movements of hand, there's spasticity. So this is another thing where the video, whether it will play. Second, let's see. Okay, so I think we'll some reason it's not playing on this. I was doing on my laptop. Okay. Okay, so this is the child showing abnormal hand movements. So in this case, coming again, clinical. What would you say clinically? Summarize. Okay, so regressions of milestones with acquired, regression of milestones with loss of acquired milestones and severe autistic features and stereotypical hand movements with decline in motor function and spasticity. So anatomically, where would you put? So this child presented with seizures. So where is seizure localized to? Cortex. So okay, so seizures, cortex, autistic features, developmental regression, lack of speech, microcephaly, they are all localized with diffuse involvement of gray matter. Yeah, so it's a gray matter. And spasticity localizes to pyramidal tracts. Ataxia localizes to cerebellum. So it's a diffuse involvement. With that pattern, you would suspect Rett syndrome. So MECP2 mutation was positive, and that is involved in maturation and maintenance of neurons, dendritic arborization, and axonal projections. So which is a cause of this thing. And etiology, as we mentioned, MECP2 mutation. So that child was positive. And yeah, another child, again, 11-year-old. I'm just put this case as short just to show you more behavioral concerns, cognitive decline, history of myoclonic, and then started having myoclonic jerks and started gradually becoming worse and worse with abnormal movements, dystonia, myoclonic jerks, and almost become non-ambulant. History of measles as a child. I think the diagnosis is obvious. And this was the child. So this is again another exam question. So this is a child showing myoclonic jerks and abnormal movements. And I think this is probably not projected that well. So what do you see here in the EEG? SSP. So yeah, so this what we call as typically periodic complexes. So you can see the waves coming quite periodically. That's 1, 2, 3, 4, 5. So they're almost periodic, high amplitude slow waves. Now another child, normal development till 1 year, history of falls, optic atrophy is there, ataxia is there, spasticity is there, axonal peripheral neuropathy is there, no organomegaly, gradual cognitive decline, loss of all milestones, non-ambulant. So where do you localize this? So white matter is there. Optic atrophy is, again, as I mentioned, is a characteristic of white matter. Then cerebellar signs are there. Then gradually this cognitive decline. So there is gray matter also become involved. So there is progressive loss of milestone. Now currently the child is completely non-ambulant, visual impairment. There is also rigidity, dystonia. All the things have settled. So this child, one of the clues in examination was, along with that, child also had a cerebellar hypoplasia. As you can see, the cerebellum is quite small. And you will see severe cortical atrophy. So this is a recent MRI. You can see this, the gyri are like finger. You can point like a finger. So that's more like a cortical atrophy. They are not like as smooth and diffuse as you would see. Suggestion of cortical, so they're more kind of defined there. So this child genetically confirmed is infantile neuroaxonal dystrophy, which has both white matter and gray matter involvement, neurodegeneration with brain iron accumulation as well, so autosomal recessive condition. So again, so as mentioned earlier, the age of onset will give you some clues. If there's a less than 2-year-old child, 2 to 5, 5 to 15 years old. So I think this charts. So these also there in Nelson. So less than 2-year-old, they're not come out that well. But those are the conditions which will commonly see less than 2 year with hepatomegaly, galactosemia, glycogenosis, MPS type 1 and 2, Tay-Sachs, Gaucher's, Zellweger, etc. Less than 2 years without hepatomegaly, you have this list of conditions: Krabbe's, Rett's, maple syrup, phenylketonuria, Menke-Kinke's hair disease, subacute necrotizing encephalopathy, Leys, Canavan, neurodegeneration, brain iron accumulation. 2 to 5 years, we have this host of this condition: Niemann-Pick, Wilson's, gangliosidosis, NCL, mitochondrial encephalopathies, ataxia, Huntington's, NBIA, neurodegeneration, brain iron accumulation, adrenoleukodystrophy, metachromatic leukodystrophy. And again, 5 to 15, you have this, again, another list of conditions, with common ones being multiple sclerosis, not that common in this part, but again, possible NCL, subacute sclerosing panencephalitis. And I think there's a list of conditions where you would see clinical clue investigations and the treatment. I think the list would be easily available. So there's some cardinal features in this which will help you to differentiate things. So as I mentioned, Tay-Sachs, cognitive and motor skill deterioration, dysarthria, dysphagia, ataxia, and spasticity. Gaucher's, hepatosplenomegaly, pancytopenia is a part of Gaucher's. Bone pain, seizures, osteoporosis. Zellweger's, there will be syndromic facial hypertonia, seizures. So child with seizure with syndromic facies considered Zellweger's. Krabbe's, irritability is a part described, limb stiffness, vomiting, slowing of mental development, which we covered. Rett's, we covered that. Maple syrup urine disease, parasitic sweet smelling urine, hallucinations, weight loss, etc. Phenylketonuria, they have hypopigmentation, so very hypopigmented hair, skin, etc. Intellectual disability, microcephaly. Then Menke's, mentioned about the hair, that is a key part. And Leys, you have like ophthalmoparesis, nystagmus. So mitochondrial disorders usually have a multi-system involvement. Peripheral neuropathy is also seen part of it. CNS, other organ systems, peripheral nerve system. Canavan's, we mentioned, it's a large head, blindness, seizures. NBIA, they have typical, they're more in the pyramidal thing. So you have this dystonia, extrapyramidal features, and they can have additional seizures, retinal degeneration, etc. Niemann-Pick, again, dysarthria, hepatosplenomegaly. Leys, we mentioned. Canavan is again mentioned. This I think we covered. Ataxia, telangiectasia, characteristic ataxia. NCL, you have this vision loss due to retinal dystrophy. As a clue, adrenal leukodystrophy we covered. There will be this adrenal insufficiency, Radisson's. Metachromatic leukodystrophy we covered. SSP we mentioned. So, so coming to the last slide, so take-home messages. So broad overview, we covered a broad overview and an approach to the neurodegenerative conditions. I know it is a lot of flowcharts. It will be hard to remember, but the basic essence is try to figure out, is it a gray matter degeneration? First of all, is it a regression? Is it a delay, or is it a pseudo regression? And then, is it a gray matter? Is it a white matter? Or other systems are also involved? And if it is it CNS only, or is it CNS and peripheral nerve system? And look for others, and examine thorough examination of other systems, as mentioned, hepatosplenomegaly, dysmorphic feature, etc. We come to the narrow down the diagnostic possibility using this CAPE acronym, and that is part of, I think, all the neurological conditions. You can use that acronyms to be it stroke, muscular dystrophy, whatever it is, and look for clinical clues. And what we haven't mentioned is the availability of genetic tests. Have recently, at a low cost, has helped to confirm diagnosis at early stage. Also, sometimes the biochemical test can be very costly, so you go to few tests and then you end up doing a genetic test to confirm, because not only that it's important, even with the biochemical abnormality, you may end up in a genetic test to confirm, and again you have to do the screening of the parents, and for the next pregnancy, be useful. Genetic counsel is essential. And I think these are the acknowledgements. And thank you for patient listening. Thank you for all the patients and parents, and thank you for attention. Any questions, please?
Thank you, sir, for the class. If anyone has any doubts, Kindly post in the chat box or unmute yourself and ask. Sir, one question is there. Is generalized cortical atrophy specific to any group of disorders?
You can please unmute and say, Dr. Rajesh, you are muted.
Okay. Now I think you can hear me. So generalized cortical atrophy can come in a host of conditions. It's not specific to one condition. As you said, all these progressive neurodegenerative conditions initially may start with only white matter involvement. But later on, they'll have cortical involvement. But it is more suggestive of a neuronal disorder, such as gray matter involvement is more characteristic of diffuse cerebral cortical atrophy, as we saw in one of these children. So NCL, this INAD, infantile neuroaxonal dystrophy. So those conditions can have cortical atrophy, maybe more prominent feature.